So good morning everyone. On behalf of Nagpur IMA, I welcome you all to this CME on diabetes. The topic we are going to cover is Diwali and diabetes, a very important topic because with festivals we all हमारे जो festivals है मिठाई के बिना होते नहीं है. मिठाई खाने से क्या हाइपरग्लाइसीमिया बढ़ता है या नहीं खाते हैं तो शुगर कम होती है या ज्यादा खाने से ज्यादा शुगर बढ़ जाती है या डायबिटीज हो जाता है. ये सब जो मिथ्स है. बाद में डायबिटीज के साथ हमने इंसुलिन लेना नहीं लेना, इंसुलिन चालू किया तो एक बार चालू किया तो रोज के इंजेक्शंस चालू हो जाते हैं. ये भी एक लोगों में मिसअंडरस्टैंडिंग है और उसके लिए इंसुलिन पे जाने को तैयार नहीं रहते हैं. तो व्हाट आर द मिथ्स एंड फैक्ट्स अबाउट इंसुलिन थेरेपी, हाउ टू मैनेज द पेशेंट्स during perioperative and operative and post-operative period, that also we should know, and festivals and sugar control, that is a very important topic that we are going to cover today in this CME. We have today Dr. Shailesh Pitale, Dr. Sunil Ambulkar and Dr. Pramod Gandhi as the esteemed faculties for this CME, and I hope you will all will be learning a lot about diabetes today from this esteemed faculties. And for further proceeding, I request Sachin Gathe to start with the CME. To introduce
a very good morning to all. Thank you, Dr. Archana Kothari ma'am, IMA President. And on behalf of IMA, I and I request our first eminent speaker, Dr. Shailesh Pitale, who is a well-known endocrinologist from the city of Oranges, Nagpur, to start his lecture on insulin therapy, myths and facts. Shailesh sir, please start.
Thank you, Sachin, and thank you, Archana, for giving me a chance to be on this forum again. And it's always a pleasure to be on the IMA forum because you get a chance to meet all your friends in today's world virtually. And as Dr. Archana Kothari mentioned, that these are important things, especially during festive times, that the diabetes management really goes haywire because of many problems, specifically because of significant change in the food pattern during the festive period. And many of the patients who need insulin, they have certain myths and facts, myths about insulin, and let's see what are the facts of insulin management. So in next 15 to 20 minutes, I'll be discussing a few myths and facts about insulin therapy. So let's see, why do we need insulin in the management of diabetes, and how well are our diabetics controlled? And if you look at the glycemic control in the Indian type 2 diabetic patients, this was a large study done in India, the IDMPS Wave 7. It showed that the majority of the patients are suboptimally controlled. If you look at the pie diagram on the left side, you would find that only 25% of the type 2 diabetic patients are within the recommended goal of HbA1c of 7%. And the mean HbA1c which was seen was about 8% in the study population. Similarly, there is another big study of type 2 diabetes, or rather of diabetes which included both type 1 type 2, the landmark study, which had a 6 months follow-up period, and it showed that only 19% of the total population of the patients studied achieved had an HbA1c of below 7%. So about more than 80%, 81% of the study population was above the recommended glycemic control. So majority of our patients are not controlled well on whatever treatment they are. When you look at the suboptimal glycemic control, that is equated with the increased risk of complications of type 2 diabetes. Now, when you look at the IDMPS study, the proportion of patients with diabetes-related complications, if you see, you would find that complications were present in about 30%. So one-third of the patients had complications related to long-standing diabetes. If you look at the landmark study, uh, here if you find that the number of patients who had neuropathy, nephropathy, retinopathy, in those who were not controlled, who were not at goal, was significantly higher than those whose HbA1c was well controlled within the goal. So what are the barriers? If you look at, despite being the best of glycemic control, the benefits of insulin therapy are yet to reach majority of the patients. So what are the basic barriers for insulin therapy, which are seen in clinical practice? And these barriers can be divided into patient barriers and physician barriers, and some which are common. So the patient-related barriers for insulin therapy are the fear of injection, the fear of needle, negative conception, the myths which we are going to discuss now, the inconvenience of insulin therapy, which the patient perceives that it is inconvenient to take, and the patient's perception of insulin therapy and recognizing or perceiving it as a personal failure. The barriers from the physician's point of view are lack of available educational tools and resources for the physician to initiate insulin therapy, the lack of familiarity or comfort level in using insulin therapy, and the time constraint, because you need to educate the patients and the family about the insulin therapy. So if there is not enough time for the physician, he should have a team who can take care of insulin therapy education and all that. There are certain factors which are common both to patient and physician. That those are the fear of hypoglycemia and weight gain, and of course, cost of insulin therapy is another concern. So if you look at insulin therapy in India in type 2 diabetes, it remains suboptimal. About 38.9% of type 2 diabetic patients are on insulin alone or in combination with oral anti-diabetic agents. And more than 10 years of post-diagnosis insulin initiation in Indian type 2 diabetics. So the time lag between starting insulin therapy and and onset of diabetes is also significant in our country. And we all know, I'm not going to go into the details of the legacy effect, but we all know that the better we control the blood sugars in the initial phase of diabetes, the better off the patient is in prevention of complications of diabetes. So when you look at these patients who are proportion of patients who are on insulin therapy at baseline in this particular landmark study, at baseline there were 25% of patients who were on insulin therapy, and at 6 months follow-up, 36% of the patients were on insulin therapy plus oral anti-diabetic agents. When we talk about insulin therapy, the recommendations are the goal of insulin replacement therapy is to normalize or to mimic the physiological insulin secretion pattern. And that is one of the things which is really difficult, to mimic the normal physiological insulin pattern. Now, the newer insulins do help us in coming close to this physiological insulin secretion, and also the insulin pumps, which are available now, help to achieve the insulin physiological secretion uh, in terms of insulin therapy that we give. The DCCT has demonstrated that intensive insulin therapy achieved near normal glycemic control and did reduce the diabetic complications significantly. And we do know that DCCT is a trial done in type 1 diabetics. There are new rapid and long-acting basal insulins, insulin analogs, whose pharmacokinetic and pharmacodynamic properties are such that they facilitate near physiological insulin delivery in the particular patient that we would choose to put on insulin therapy. Multiple daily injection basal bolus regimens with long-acting and rapid-acting insulins are given to take care of the meal-related hyperglycemia and basal insulin for fasting hyperglycemia. And as I mentioned to you, insulin pumps are a good option for for achieving near normal physiological effect of the insulin therapy. Now, there are various insulins which are available in the market. And there are, as I mentioned to you, there are the insulin analogs, which are available, the long-acting analogs and the short-acting analogs. Why am I mentioning these here? These are convenient to use, and some of the myths related with insulin therapy are actually taken care of by these insulins. The long-acting insulins like insulin detamir, glargine, degludec, and glargine 300 are the insulins which can be given once a day and irrespective of the meal that the patient is taking. And short-acting, ultra-short-acting insulin analogs like aspart, lispro, glulicin are ultra-short-acting, and these insulins have the benefit that you can give these insulins immediately after meal also. So let us look at what are the various myths of insulin therapy and what are the facts related to it. One of the myths is insulin is prescribed for type 1 diabetics only. In type 2, if the insulin is required, the patient is a type 1 diabetic. That's a big myth. Many patients assume that insulin therapy is given only for type 1 diabetics whose capacity to make insulin by the islets of Langerhans is completely gone. However, it is very well known that type 2 diabetics also need insulin therapy, especially that may be required for a short period of time, sometimes in acute conditions when insulin is required, or in certain type 2 diabetic patients over a period of time, they would need insulin therapy along with oral anti-diabetic agents because over a period of time, as per the natural history of diabetes, the beta cell dysfunction sets in. Beta cell dysfunction, which is already there, leads to significant deficiency of insulin and which is not taken care of by oral anti-diabetic agents. And at that point of time, the type 2 diabetics would need insulin therapy. Another myth of about insulin therapy is taking insulin means you are at the last stage of diabetes. And this is one of the big myths that the patient and the patient's family members have, that now that I have to be put on insulin means I am at the final stage of not only of diabetes, but of my life. That's the perception that many patients do have. And that is because earlier the concept was insulin was started very late in the therapy of diabetes. And sometimes patients do feel that when everything has failed, now insulin is being given. But the fact is, type 2 diabetes, we all know, is a progressive disease. And most patients would eventually need insulin because, as I mentioned to you earlier, the insulin secreting capacity of the beta cells is significantly reduced. And when it drops to a particular level, when even oral antidiabetics cannot take care of the glycemic control, insulin therapy is required. So insulin therapy can be given in early stages of diabetes also, not only at the late stage. Another important thing is many times we clinicians, when a patient presents to us with diabetes at the time of diagnosis, we may consider starting insulin therapy to bring down the sugars rapidly to normal glycemic control, especially in young population if the sugars are very high, considering the legacy effect. We want to have good control right in the beginning so that you can prevent the complications of diabetes in future. So by using insulin to keep their diabetes in good control, the people with type 2 diabetes can avoid complications and have a healthy life in future. So it's not that it is the end stage or last stage of diabetes that you need insulin. Another important myth that the patients and the family have is insulin therapy causes significant pain. And majority of these patients and the family members have needle phobia, and they're hesitant to take insulin injections because of the fear of the needle. But they would be relieved to note that the insulin needles which are available now are so small and so fine that they do not cause any pain. They just inject the insulin below the skin, so the length of the needle is also very small. They are very fine and sharp, thus the pain is absolutely not there. We know that the nerve endings are situated a little bit deeper and they are left untouched. Predominantly they really do not cause any type of pain. And what I practice in my clinic is I usually make the patient to take the first prick in the clinic where in front of the diabetes educator. The diabetes educator makes the patient prick himself or herself in front of her so that the fear of needle is gone. And that's very important. So these needles are absolutely painless, which are available now. Another myth is insulin use by type 2 diabetics will result in weight gain, which is always harmful. Yes, insulin therapy causes weight gain. Weight gain is noticed in diabetics after insulin therapy is initiated. But we all know that insulin is an anabolic hormone, and when patient goes in insulinopenic state, it causes a catabolic state in the patient, and that weight loss is not a good weight loss. And you would find that majority of these patients who come to you with very high blood sugars, have severe insulinopenia, will give history of significant weight loss, and that indicates that the beta cell failure is significant. And when you initiate insulin therapy, these patients gain back their weight, and that weight gain is a normal weight to which the patient usually returns. This happens due to the process which, as I mentioned to you, insulin is an anabolic hormone. And of course, it has been noted that in some patients, there could be some amount of weight gain, some amount of fat gain in diabetic patients, but that excess weight can be taken care of by proper diet and exercise, and also giving patients certain oral agents like metformin, which can help the insulin to work better, the insulin sensitivity is improved, and the risk of weight gain is reduced in these patients who are given insulin therapy. Another important myth is if I would take insulin, I would definitely suffer from hypoglycemia, which is a life-threatening event. So hypoglycemia is the effect of insulin therapy. We all know that hypoglycemia, we want the sugars to come down. So it is the insulin's effect is hypoglycemia. And if it goes beyond a particular level, it can be dangerous. And then we call it as a side effect of insulin therapy. It can easily be prevented by maintaining proper medication schedule and proper diet. The diet, if the patient is on insulin therapy and misses his or her meal, the risk of hypoglycemia is definitely going to be very high. It is important to identify the symptoms of hypoglycemia early. We need to educate the patients about hypoglycemia when we put the patient on insulin therapy. And the risk of hypoglycemia can be significantly minimized by the choice of insulins. And that was what I was describing to when I showed you the table of various insulins. You have long-acting insulin analogs, the basal insulins like the Levemir, the Glargine, the Degludec, and the U300 Glargine. These are basal insulin, these are peakless insulins. And these do not, the incidence of hypoglycemia is significantly low with the use of these basal insulins. And the ultra short acting analogs like aspart, then glulisine, these do have, and lispro, these do have significantly less hypoglycemia because of the short duration of action that these short acting insulin analogs have. So if you titrate or if you choose the insulins properly in your patients, if you educate them well about the proper meal timings and meal contents and proper exercise schedule, the risk of hypoglycemia will be reduced. And we have to educate our patients about the symptoms of hypoglycemia when we put the patient on insulin therapy. It is extremely important for we clinicians to make these patients aware about what are the symptoms of hypoglycemia so that they recognize the symptoms of hypoglycemia and treat themselves if they have hypoglycemia. Other methods, insulin therapy means significantly healthy lifestyle habits have to maintain, and healthy lifestyle habits need not be maintained, and we can do anything if we are on insulin therapy. That is another myth. People do say that मेरी शुगर बढ़ जाए डॉक्टर साहब मैं जब मिठाई खाता हूँ मेरी शुगर बढ़ जाती है. You tell them that you have to control your food and have proper meal. They then tell you that डॉक्टर साहब आप तो मुझे इंसुलिन दे रहे हैं. But you have to explain to them that being on insulin therapy doesn't mean that they can have any unhealthy lifestyle, and insulin cannot take care of such unhealthy habits. So healthy habits are always meant to be followed no matter what state the person is in. Insulin therapy doesn't mean that you can eat anything unhealthy and forget about the precautions. So these facts have to be told to the patient by the diabetes educator. And one has to have adaptation of a healthy lifestyle along with insulin, and that can contribute to make the person fit, healthy, active, and prevent the long-term complications of diabetes. So actually, when you put the patient on insulin therapy, that is a point when diabetes education can be reinforced by our diabetes educators. And that is one point where I make the patient sit with the diabetes educators. So all these facts can be again reiterated by our diabetes educators to our patients. Now, insulin therapy will bound you in ways. That's another thing, another myth that the patients have. They feel that once they are put on insulin therapy, they are bound. Their freedom to move around, they have to have meals on the same time, and when they can't go for parties, they can't have enjoy their life. These are certain things that they feel. But the fact is, insulin therapy does not bind or restrict the person, a diabetic patient, anyhow. That's usually one, people feel that they cannot travel. Actually speaking, the insulin pens are so convenient, even if they are on insulin syringes, they are so compact, and the insulin kit is so compact that they can use that travel kit even when they are traveling. Newer insulins, which I explained to you, give you better flexibility about timings. And some of these patients, especially the executives who have whose timings cannot be fixed, they can be handled with these newer insulins better, in which case their hypoglycemias are also reduced and hyperglycemia can be taken care of by these newer insulins. So these newer insulins give much better flexibility, and these patients are not bound. And coming to the last myth, which I am mentioning here, is insulin therapy will be continued lifelong. That is another myth that many patients have. In fact, in type 2 diabetes, insulin use can be temporary, and as I mentioned earlier, in some patients, the at initiation or at diagnosis of type 2 diabetes, they may need insulin therapy to control blood sugars better at the time of diagnosis if the sugars are very high, because we know that earlier you control the sugars, the better is the legacy effect. And then once you control the sugars better with insulin in the beginning, then the insulin can gradually be tapered off and patient can be put on insulin on oral therapy. So many times we start the patient with bedtime insulin and daytime oral agents, which is called the BIDS therapy. That is bedtime insulin and daytime sulfonylurea. That was the initial short form, but it need not be sulfonylurea, it is other agents. So bedtime insulin and daytime oral agents is many times a favored therapeutic regimen which is given. Similarly, in gestational diabetes, we know that insulins are given, and insulin therapy is temporary in majority of these gestational diabetes patients. And once the delivery is the lady delivers the baby, insulin requirement significantly goes down, and majority of these gestational diabetic patients are off insulin once they deliver the baby. There are certain acute conditions which may require temporary insulin therapy, like acute infections. If the patients have any type of acute infection, when there is decompensation of the glycemic control, may need insulin therapy. Surgery, which Dr. Ambulkar is going to discuss, the surgery is one event where insulin therapy may be required temporarily, and post-operatively one can again go back to oral agents. So we need to educate the patient that insulin therapy always doesn't mean it is permanent. It can be temporarily given. However, in some long-standing type 2 diabetics, when they are already on good amount of oral agents, they may need to be started on insulin therapy, and then that in that situation, it may have to be given on long-term permanent basis. Now, another thing is insulin timings are rigid. That's another thing which patients feel. Actually, as I mentioned to you, the insulin analogs, the newer insulin analogs give good amount of flexibility. The short-acting analogs, as I mentioned to you, can be given 15 minutes before or even 20 minutes after meal, like the Aspart, the Lispro, and glulicin. These are very much beneficial, especially in young patients, in children. They can be, because many times they are playing and also, and you are not sure how much they would have the intake. So after they eat, the insulin can be given. Similarly, in old population, in old patients whose intake is not guaranteed, these insulins can be given immediately after food. One can titrate the dose based on how much the patient has consumed in the meal. So that reduces the risk of hypoglycemia. The long-acting analogs like glargine and degludec give a better flexibility to us. Dear friends, in last 20 minutes or so, I have tried to discuss the various myths of insulin therapy that these patients have. And it is very important to understand these myths and what are the facts related with it. And we need to educate our patients so that the fear of insulin therapy is not there, and we achieve a better glycemic control in our patients who need insulin therapy. Thank you very much. I'll stop sharing my screen and would hand over to Sachin. Thank you.
Thank you, sir. Very nice, informative lecture on insulin therapy, myths and facts. Of course, the barriers are patient, accordingly, patient and physician inertia. Very important discussion here. And the legacy effect of insulin, very important fact about the early starting of insulin therapy. And as yes, insulin is the not the end of winning. The message is clear from the Shailesh Pitte sir. I thank you very much, sir, on behalf of IMA.
Thank you,
The
Sachin.
second eminent speaker, consultant endocrinologist, Dr. Sunil Ambulkar, will speak on perioperative management of diabetes, and I request him to start his lecture. Sunil sir.
Good morning. I am in Nagpur. Good morning, President, Secretary, and Sachin. Thank you very much for conducting this excellent program. Shailesh has made my topic little easy for me by talking on insulin therapy. My topic is perioperative management of diabetes mellitus. Why it is important to control diabetes during pregnancy? There is a unique interaction of surgery and diabetes. High blood sugar level increase risk of surgical complications. Mental physical stress of surgery, infection, obesity, and medications at times can lead to hyperglycemia. As you know, prolonged hyperglycemia causes increase in chance of infection. There's a prolonged hospitalization. 20% days will be more required if the patient is diabetic than non-diabetic as far as the hospital stay is concerned. There can be thrombotic complications, renal insufficiency, high hospitalization cost as well. And as mentioned earlier, hypoglycemia with insulin therapy and related morbidity and mortality is a problem which needs to be tackled. Studies have shown the preoperative glycated hemoglobin A1C more than 8. This patient require a long hospital stay. Perioperative management of diabetes. What should be the initial assessment of the patient? It's important to take complete history of the patient and examination, find out the comorbid conditions, because diabetes comes as a basket. Every alternate diabetic can have hypertension, every second diabetic can have lipid problem, and they have subtle micro and macrovascular complications which needs to be investigated and properly monitored. Baseline investigation, as I said, glycated hemoglobin A1C, 7-point blood sugar monitoring, kidney function tests, especially basal potassium assessment and potassium replacement, and its management is very important. Blood sugars are high, then one has to rule out diabetic ketoacidosis or hyperosmolar state in an elderly population. ECG, chest X-ray, and screening for infection is important. Baseline liver function test, uric acid, which is a marker for insulin resistance, should also be done. Markers related to infection elsewhere in the body should be done at the basic level and monitored over a period of time. It all depends whether it is an emergency surgery or a planned surgery. Emergency surgery, patient requires settlement of fluid and electrolyte balance, blood sugars by IV insulin, and might require 4 to 6 hours before going in for emergency surgery. Planned surgery is relatively easy to tackle. As I said, there is a 7-point scale of blood sugars or 2 to 4 hourly blood sugar record if the patient is on IV insulin therapy, fasting blood sugar, pre-lunch, post-lunch, pre-dinner, post-dinner, and 3 a.m. to find out nighttime hypoglycemia should be done. If the glycated hemoglobin was high, that indicates previously undiagnosed or uncontrolled diabetes. If your blood sugar is high at the time of illness, but the glycated hemoglobin is normal, that indicates it is stress hyperglycemia. This situation of hyperglycemia can bounce back to normal, revert back to normal when the stress of surgery is over. What level of control one should aim at in a patient with a perioperative surgical patient? Fasting around 100 to 140 and post-meal around 140 to 180. Below 180, maybe in a patient who has comorbid conditions of heart, kidneys, or elderly population, one can go up to 200 milligrams. We can monitor these patients by 7-point program. Now we have got continuous glucose monitoring. A small machine has to be kept on the body. It's like a small instrument, and that continuously will give you blood sugar record. This is not done in every case, but one can do it in a highly motivated, technically capable, and one has to change the insulin therapy accordingly. It can take a snapshots as well. These are the list of oral anti-diabetic drugs which are very sparingly used during surgery. Only minor drugs need to be used, and few drugs are to be practically stopped before day or 2 days before surgery. In the perioperative period, one has to avoid metformin, glyphazones, ARBs if possible, and NSAIDs. You have to reduce the dose of NSAIDs, reduce the dose of ARBs, or avoid them when the patient has got hypotension or fluid depletion, because they can exacerbate acute renal insufficiency. Shailesh has told you about insulin pharmacokinetics and pharmacodynamics. There are inter-individual and intra-individual variation. So the managing of insulin therapy also depends on the type of insulin you are using, the mode of insulin you are giving, inter-individual and intra-individual differences, and insulin technique, storage, and monitoring, which I will talk in a minute. As I said, minor or major surgery aim is to have adequate control of blood sugars. Minor surgery like cataract extraction or tooth extraction, one can continue with oral anti-diabetic drugs. But for major surgery, one has to stop oral anti-diabetic drugs for a day or two before. The therapy will depend on the NBM status of the patient post-op. Metformin has to be stopped for at least a day or two before surgery. Second generation sulfonylurea has to be stopped 1 day before. Glitazones and glyphazones 1 day prior. One can give night dose of insulin normally before the surgery, planned surgery. One can watch morning blood sugar levels and can omit or reduce the dose of morning insulin by half. The bottom line is one has to monitor blood sugars 1 or 2 hourly. The NBM status will determine the insulin therapy. Either you give glucose, potassium insulin, or in a separate drips. One has to start subcutaneous insulin therapy when the NBM status is over. So what will be the management of patient in a patient who has NBM or who has prolonged surgeries? This can be of two groups. Patient with NBM status, medical and surgical ICU should be the better place for management. There are various protocols. One protocol was to give IV insulin, DNS and potassium. Give 8 to 10 units of regular insulin in 5% dextrose and potassium supplement. But now we use separate drips. Like 50 units of insulin in 50 ml of normal saline, and separate DNS drip at the rate of 100 ml per hour. That means around 2.5 liters to 3 liters per day. If the patient has got infection, if the patient has steroids for one reason or another, obesity or CABG or illness, then the insulin requirement will drastically increase. One has to monitor blood sugars, one has to monitor potassium and supplement potassium. If you look at a patient, a post-CABG patient, they are the most insulin resistant state. In fact, it is our experience that after CABG, for initial 2 days, the patient is only on IV insulin without the need of supplemental glucose. They are so much insulin resistance because of massive sympathoadrenal discharge that this patient require IV insulin for 2 to 3 days without glucose supplementation. Now, IV insulin protocols, there are various protocols. Every hospital should have its own protocol and the ways of managing it. Insulin infusion is in 1:1 proportion, 50 units of regular insulin in 50 ml of normal saline. You can give IV bolus dose with monitoring of potassium and initial infusion rate. The initial blood glucose, suppose it is 400, then we can divide it by 100 and give at least 4 units of insulin safely. Then depending upon the blood sugar, you have to start the infusion rate. As I said, obese patient, patient on steroids, patient with infection, this rate needs to be increased. A separate line of 5% or 10% dextrose can also be given for the calorie. You have to check blood sugars, target blood sugars at 140 to 180, less than 200. If the blood sugars are less than 150, you stop the infusion for 1 hour, recheck sugar and decide accordingly. If you follow this, this will give you a smooth control of blood sugar in a post-operative state when the patient has got nil-by status for a day or two or more. If the patient is eating orally, normally tube feeding or diabetic formula diet, then there are various subcutaneous insulin regimens. One is basal and bolus, what Shailesh was talking. Give a basal dose of 0.1 to 0.2 unit, either NPH, glargine or detamine, and add boluses at breakfast, lunch and dinner. The another simpler regimen would be give mixed insulin 50-50 with breakfast, lunch and dinner. In fact, breakfast and dinner mixed 50-50 and lunch give regular insulins. We should be using more of 50-50 insulins rather than 30-70 because the Indian diet from north to south and east to west is more of a carbohydrate based diet. Carbohydrate requirement, the content of carbohydrate calories would be 60 to 65%. To tackle this carbohydrate load, it is better to have more regular insulin which are short acting. So it's our, I personally feel we should be more using 50-50 rather than 30-70. In Western world, they have a high protein diet. This is a non-veg based diet. Their proteins are more, that requires less insulin, regular insulin and longer lente or NPH or whatever insulin. So for those 30-70 is fine. Again, the sliding scale insulin which you are using is not physiological. For example, if the patient blood sugar at night after dinner is 280 and 300, and if you give 15 units of insulin, then the patient will immediately land in hypoglycemia at 3 a.m. because insulin will act and patient was not eating. It's better to have basal and bolus regimen or mixed conventional insulin therapy rather than sliding scale insulin, which is not physiological. So this is the basal and bolus dose, or this is the conventional dose. One word about insulin storage, insulin use and insulin technique. Insulin should be storage, should be not directly exposed to sun. If you store in a refrigerator, then you have to take out the insulin syringe or insulin vial and have it to the room temperature. If you immediately give, that cold insulin will not act properly. Now the insulin syringes are so small that we should not give at 45-degree angle. I find this is the commonest reason of uncontrolled diabetes in hospitals. The sisters are still in in a habit of giving insulin at 45-degree angle. The needle length is so small, it doesn't go intra subcutaneously, it goes intradermally. So insulin injection technique has to be taught properly to the sisters. It should be given vertically in outer part of thigh, outer part of arm, or in abdomen where the site is feasible. But this three insulin storage, insulin use, and insulin injection technique should be properly taught to the paramedical staff. So this is the simpler version of how to calculate. Suppose the patient is of 60 kg weight, you divide it by 2, that is 30 units. Then again divide it into 3 parts, do 2 parts in the morning and 1 part in the evening. That is morning 20 units of mixed 50-50 and evening 10 units. Now with infection, with obesity, with steroids, this insulin dose might increase. One can add a regular insulin with breakfast and shift mixed 50-50 at breakfast and dinner. It is suited with those patients who have fair regular lifestyle, fixed diet pattern and exercise schedules, who eat normal similar quantity of food each time. This can also be tried in a post-operative stable patients. This is the conventional insulin therapy I was talking about. This is mixed 50-50 before breakfast, before dinner, and regular insulin before lunch, or mixed 50-50 in lunch and dinner if the patient is not taking proper breakfast. This is suitable regimen and comfortable regimen for the patient. You have to adjust the insulin therapy according to the blood sugars. The fastings are high, then you have to increase the nighttime NPH or long acting. If the pre-lunch, pre-dinner and post-dinners are high and low, you have to increase the pre-breakfast, pre-lunch and pre-dinner blood sugar according to the blood sugars. If all are high, then you have to adjust basal and pre-meal. The one thing which I would like to suggest to avoid hypoglycemia is, if you give conventional insulin, which is mostly managed, it acts at maximum time in afternoon 4 to 6 p.m. So always you ask your patient to have some snacks at 5 p.m. And if you give a citrus fruit and 1 cup of milk at night at 11 p.m., your patient will not have dangerous hypoglycemia. If the blood sugar post-dinner is around 160, then again your patient is safe. Post-dinner blood sugar of 160 and the patient is eating 1 citrus fruit, a small apple and a cup of milk, he is unlikely to have a dangerous hypoglycemia, which becomes much more dangerous during night time than daytime, for the obvious reason that the patient cannot be monitored properly throughout night. So this is one of the ways of avoiding hypoglycemia, because the most important fear among the patient and physician about the insulin therapy is that it causes hypoglycemia. But properly used in proper doses with proper precautions, insulin therapy will control blood sugars, avoid infections, patient's surgical outcome will be better, and definitely will avoid hypoglycemia. I think I should stop here, and we will be sharing questions after the talk, I suppose. Thank you very much.
Yeah, thank you, sir. Thank you very much. After a elaborative lecture on perioperative management of diabetes, of course, how to monitor the blood glucose, some facts about stress hyperglycemia, and the rational use of oral anti-diabetic during the peri-surgical period. And of course, how the sidling scale is not feasible, it is not physiological. So message is clear. If you control the sugar, good control of sugar, HbA1c is less than 8, then your hospitalization period is reduced. Thank you very much. Now there are no question from participant side, so we will skip that session. I will ask the question at the end. The next lecture is on Diwali and diabetes. Actually, diabetes and festival. Basically, it's on fasting, and which will be taken by eminent diabetologist and endocrinologist from Kingsview Hospital, Dr. Pramod Gandhi sir. So I will request Pramod Gandhi sir to start his lecture. As you know, this CME is organized on the occasion of World Diabetes Day. This is a diabetes month. So this on occasion of World Diabetes Day, we have organized this CME, and as well as Diwali is going on. So we thought that there must be one topic on Diwali and diabetes, as the sugar goes haywire during this Diwali because of uncontrolled diet and monitoring. Uh, Gandhi sir?
Yeah. Thank you, Sachin,
Yeah.
for that kind introduction. And
Thank
I'm sorry for the my apologies for the slight problems related to the display and net connectivity. I remember when we were discussing how do we celebrate the World Diabetes Day this year. That time it was a occasion of Diwali, and that time myself and Sachin we thought that we should discuss a topic which is related to diabetes and Diwali. This is because we had seen most of our diabetic patients who come post Diwali, for that matter, any after any festival where we celebrate, we had seen that most of these patients are uncontrolled, and there are various reasons for these uncontrolled diabetes. So we thought, why not to discuss that topic? When I spoke to Dr. Chadamaru, she also suggested me to talk on even a few words on therapeutic lifestyle changes in patients with diabetes as well. So in next 15 to 20 minutes, what I'm going to do is I'm going to talk on these two topics, Diwali and diabetes, and maybe therapeutic lifestyle changes. We all know culture and religion plays an important role across the world, globally, in all population. And in India, we are seen we are the people who celebrate everything. Majority of the Indian festivals are considered to be synonymous with the eating, feasting, and gifting the sweets. And there are n number of these festivals, whether you talk about the Diwali, Navaratri, Ramadan, Ganesh Chaturthi, Christmas, whatever you talk about, we always celebrate all these festivals. And these are the festivals where there are different types of celebrations. In some festivals, we do fasting. In some festivals, we do feasting. But even in the festivals where we do fasting, like Ramadan, where the people do fast, but at the end of the fasting, they eat a lot, and we have seen that most of these patients are uncontrolled, and at the end of Ramadan, these patients do gain weight. Most of the religious food festivals involve food, usually feasting, preceded by fasting. Some include also alcohol and mind-altering substances, which are potentially dangerous. Festivals may involve long journeys to holy places, and people go to their home places if somebody is working outside. These festivals are sometimes period of stress and anxiety as well, whether it is fasting or feasting. Health occasions where these people fast. These fasts can last for up to a month, depending on your festival. The fasting characterized by documented impact on metabolic health in healthy people. In diabetic, their festivals do fluctuate as fast patient may vary. So, who are the patients who are at risk during fasting? That patients with poor glycemic control, whose HbA1c is very poorly controlled, recent history of diabetes ketosis, patients with late established micro as well as macro complications of diabetes, those who are associated with severe comorbidities, infection, pregnancy, elderly population. These are the people at high risk. There are definite guidelines for the management of diabetes during fasting, which has been laid down for the management of diabetes during Ramadan. Similar guidelines can be followed. But there are so we were
Yes, sir.
talking about the
Yes, it is.
guidelines during the management of fasting, which has been laid down, especially the guidelines for the management of diabetes during Ramadan. The similar guidelines can be followed for any fasting, but there are no specific guidelines which has been laid down for feasting and diabetes. But we know at feasting there are many occasions where we eat sweets, especially Diwali, where we see. Uh, Especially during Diwali, we see that we eat a lot of sweets, mithai, barfi, cakes, and much effort goes into food preparation of these foods, and then that increases the stress. A challenge during this time, there is a challenge for everyone trying to maintain the balance between the healthy diet and the glucose control by proper glucose lowering medications. It has been found that in US that during Thanksgiving ceremony or Christmas, most of these patients gain maybe 0.8 to 1 kg within a month. Similar findings have been seen even in Ramadan. Most of these patients do gain weight. So we have not studied similar things about the various festivals which we are celebrating in India. But yeah, so major contributors towards the inadequately managed diabetes during festival are there are sudden changes in the dietary habits, lack of physical activity, poor monitoring. Most of these patients delay their monitoring of glucose control. Most of the patients says that recently I have ate lot of sweets, so we will not monitor your diabetes, and they monitor their blood sugar after 15 to 20 days, and that's how they don't monitor the sugars. These patients take irregular medications, maybe because of negligence, maybe because of non-availability of the medications during this period. And therefore, there are potential diabetes related complications, like patients can develop hypoglycemia. Some patients do take excess medications if they eat sweets. Some patients don't take medications, and therefore there is hyperglycemia, diabetic ketoacidosis, HHNS can be seen. Even these lot of fatty foods which we eat during the festival season, lot of carbohydrates which we eat during festivals will also alter the lipid profile, and therefore there are various complications of diabetes which we can develop. During Diwali, there are various reasons why our sugars go high. These people eat high carbohydrate, high fat diet, erratic food timings, altered daily routine, missing of exercise, altered sleep-wake cycles, decreased physical activity. All these factors contribute in the development of hyperglycemia. Even medications, especially insulin, which is often missed during this festival season, this can further lead to development of various complications of diabetes. Also, the lipid alterations which we see is in these patients, HDL cholesterol is reduced significantly, triglycerides and VLDL levels are increased significantly, total cholesterol levels are increased. This leads to, this is associated with the increased blood viscosity, which results as a dehydration, and diabetes itself is a endogenous condition which increases the prothrombotic stage, leads to increased risk of coronary artery disease and stroke with during this festival season. It has been shown in NHS Christmas study where they say that patients are given warning to store enough insulin and medications so that during festival season pharmacies which are closed, and hence they should not have inadequate stock of medications. Also, it was found that compared with the admissions which occur during the festival season, the mortality was 48% higher. 7 days mortality was 48% higher, and 30 days mortality was 27% higher in those patients who were admitted during festival season in the hospital as compared to those patients who were not admitted, who were admitted at other times. So this is very, very important finding. So it's not only morbidity, but it also increases the mortality. And who are the patients who are at high risk? There are various categorization. Now this high risk can be for both hyperglycemia as well as for hypoglycemia. There is very high risk for patients who has wide fluctuations in the blood sugar, who has recurrent hypoglycemia unawareness, decay, HHNS in the past, patient who has acute illness, patients who are performing intense physical activity, pregnant women, patients who with chronic renal failure who are on dialysis, elderly population, patients with various micro as well as macrovascular complications of diabetes, and the patients who are healthy otherwise and who are on anti-hyperglycemic medications, not hypoglycemic drugs like metformin, glitazones, DPP-4 inhibitors, and maybe SGLT2 inhibitors. These are the patients who are at low risk for development of both hypo as well as hyperglycemia in these patients. So we need to prevent diabetic ketoacidosis, and especially in type 1 diabetes, and hence we should explain a sick day plan to the patient, discuss the sick day plan and explain the management of diabetes during such festival season. Monitoring frequency should be increased and they should be advised about regular insulin doses and they should not miss insulin during this period. Clinical assessment is very important and patient education plays a key role in the prevention of various acute and chronic complications of diabetes during this festival season. This is very, very important. The key to the success of management of diabetes during festivals is frequent monitoring, nutrition, maintenance of nutrition, adequate regular physical activity, and regular medications. If these four things are followed, probably we can definitely prevent the complications of diabetes. Now I will discuss about a word about the therapeutic lifestyle changes which is required for a otherwise a healthy diabetic patients. Therapeutic lifestyle changes includes diet, what we call as medical nutrition therapy, physical activity, and behavioral modifications. Now, the aims of medical nutrition therapy or MNT is to achieve and maintain the adequate body weight. We need to attain the individualized glycemic goals. Now, individualized glycemic goals means in a patient, young patients, we aim for tight control. In an elderly patient with comorbid conditions, we aim for little relaxed goals. So you have to individualize the HbA1c targets, blood pressure targets, lipid targets, and we try to maintain this by nutrition. And similarly, we need to prevent the long-term complications of diabetes. This should be achieved based on patient's nutritional needs to be assessed based on patient's personal cultural preferences, education or literacy of the patient, access to the various foods, and willingness and ability to make the behavioral changes to maintain the adequate nutrition so as to control the blood sugars, blood pressure, and lipids to reduce the long-term macrovascular as well as microvascular complications of diabetes. At the same time, we need to see that patient should maintain the pleasure of eating, and for that we need to provide the practical tools for developing these behavioral changes in the eating pattern, and we should be able to provide various micronutrients as well as macronutrients to these patients. These are the guidelines which are recommended by the ADA, that we need to maintain the balanced nutrition by individualizing the patient's diet pattern. Now, individualization means we need to assess the patient's present diet pattern, patient's present calorie intake, patient's calorie requirement, food availability, and patient's lifestyle. Based on that, we need to advise a diet which is suitable to that individual. We need to maintain the energy balance, whether we want to maintain the body weight, whether we want to lose body weight. If at all patients are overweight and obese, probably they should lose 5% of the body weight, and for that we need to reduce the calories intake. Eating the macronutrients like carbohydrates, proteins, and fat, there is no single ideal dietary distribution pattern which is described for any patient. We need to individualize. There are 58 different types of diet which has been described for weight loss. Similar dietary patterns has been followed even in diabetes, but none of them is ideal. Overall, we need to see that patients should be able to take 45 to 50% of their calorie intake should be in the form of carbohydrate. In Indian diet, we are seeing that most of our diet has almost 65 to 75% of the calories are in the form of carbohydrate, which we need to reduce to 45 to 50%. The protein intake, especially in vegetarian population, is very, very poor. We need to see that these patients should be able to take 15 to 20% of their total calories in the form of protein. Similarly, dietary fat, which is also an essential component of the diet, should be in the form of 27 to 30% of the total calories, depending on patient's lipid profile. We have to see that patients should have balanced nutrition, which is helpful them for maintaining their metabolic as well as physical targets. The various micronutrients or dietary supplements, vitamins, minerals, chromium, selenium, vitamin D, vitamin E, all these things, whether these things are helpful or not, it has not been clearly shown in any of these studies. So there is no evidence, clear-cut evidence to say that these things are useful in diabetic patients. Alcohol should be taken in moderation. It should be, as far as possible, it should be avoided. And while taking alcohol, the patient should be advised to take adequate meals. Otherwise, the chances of hyperglycemia and hypoglycemia are very, very high. The sodium intake should be restricted to less than 2.3 gram per day. And not nutritive sweeteners or artificial sweeteners can be taken in a limited amount in most of the diabetic patients. In short, diabetic patients should eat regular meals. They should aim for at least 5 portions a day of fruit and vegetables, limit sugar intake, reduce fat intake, aim for 2 portions of oily fish, especially those patients who are taking non-vegetarian diet, or those patients who are taking vegetarian diet. They should include beans, lentils, and pulses to increase the protein intake in their diet. Oily foods and alcohol intake should be avoided in these patients. A word about physical activity. In patients with type 2 diabetes, these patients should be engaged in minimum 150 minutes of exercise per week, and it should be spread over at least 4 to 5 days a week, out of which 3 days should be intensive, vigorous intensity aerobic activity, and 2 to 3 sessions of resistance exercises. There should not be gap of 2 consecutive days without any activity. A shorter duration of more than 75 minutes per week of vigorous intensity may be advisable in younger patients intermittently. We need to decrease the amount of time spent in the daily sedentary behavior, especially professions like ours, where prolonged sitting is seen. So we should have interrupted sitting every 30 minutes so that our glucose levels are maintained. Flexibility training, balance training are also recommended 2 to 3 times a week. Yoga and Tai Chi may be advised based on the individual preferences in these patients. In short, our body weight is a simple balance between calories in versus calories out. We need to see that we need to reduce the calorie intake and increase the calorie expenditure to maintain the body weight. Eating of around extra 100 calories, there are few examples like 100 calories excess of intake per day can cause 4 to 5 kg weight gain. Similarly, 100 calories per day deficit continuously for a year may cause 4 to 5 kg weight loss as well. So we need to see that the calorie intake should be reduced if you want to lose weight, and it should be sustained. Most of the times what happens, we do calorie restriction for 4 to 5 days, and on Sundays we do binge eating, and we spoil the whole week's diet control, and then we say that in spite of diet control we are not losing weight. In obese patients where your aim is to maintain more than 5% weight loss, in such patients, these patients might need high intensity exercises, maybe 3 to 4 sessions per month, or maybe more than 16 to 20 sessions in 6 months. And initial rapid weight loss should be followed by maintenance of sustained weight loss. And in these patients, though we say that in diabetic patient 150 minutes of exercise is sufficient, in patients in whom we aim for weight loss, these patient needs 200 to 300 minutes of exercise per week. That's approximately 60 minutes of exercise per day. At least 5 to 6 days in a week should be advised in these patients with intermittent high intensity exercises. That should be advised. Maintenance of weight is very, very important. So initial loss of weight should be followed by maintenance weight loss programs. And we have to see that even exercise pattern should also be individualized in these patients, for which we need to do monthly contact, regular contact with these patients so that they can lose weight properly. Very low calorie diet, that's approximately less than 800 kilocalories per day, may be advised in certain situations, but we need to see that these patients should not develop any complications while advising very low calorie diet. So that, and in these patients, in long term, weight maintenance program should be advised. And those patients who cannot control their weight by diet, exercise, and behavioral therapy, probably these patients might need pharmacotherapy or metabolic surgery in future. In short, during festival, we need to see that we should limit the intake of sugary foods, increase the fruit intake, fresh vegetables, drink sugar-free fruit juices, and adequate water intake should be maintained. Typically, the foods which are rich in oil and deep fried food like paratha, puri, pakoda, Diwali sweets, laddu, karanji, chakli, these things should be avoided or minimized as far as possible and should be replaced with your calorie intake. And if you want to lose weight, your 50% of the diet should be fruits and in the form of fruits and vegetables. Those patients who are not controlling diet during festival season, they will have persistent, poorly controlled diabetes. Initially, they will have postprandial hyperglycemia, later on fasting hyperglycemia, and this will lead to poor glycosylated hemoglobin and ultimately long-term complications of diabetes. Now, postprandial hyperglycemia is the main thing which we see, especially in seasons like Diwali. We need to control postprandial hyperglycemia in such festival seasons. Otherwise, also, if during such festival season, you see that most of the time which we spend in 24 hours is in the postprandial post-absorptive phase, where your sugars are persistently high during daytime and patients can develop hypo during night time. So we need to control these patients' hyperglycemia by various ways. There is clear-cut evidence that postprandial hyperglycemia is also harmful for patients with diabetes. They can develop various microvascular as well as macrovascular complications, including increased risk of coronary artery disease due to various reasons like oxidative stress, inflammation, endothelial dysfunction, atherosclerosis, contributing to the increased risk of cardiovascular complications. This has been shown in various studies as well. And hence we need to be very, very aggressive in terms of management. Today, I am discussing, or I am restricting my discussion to mainly on therapeutic lifestyle changes, where we talk about diet, exercise, behavioral modification. And if not, probably these patients might need oral anti-diabetic agents and rapid up titration of various anti-diabetic agents along with insulin if required. These are the various anti-diabetic agents which are available to us for the management. Today, I am going to focus only on postprandial hyperglycemia, for which we have alpha glucosidase inhibitors, we have glinides, we have short-acting sulfonylureas, short-acting and rapid-acting insulin and insulin analogs, GLP-1 analogs, and DPP-4 inhibitors. These are the drugs which might help in controlling the postprandial hyperglycemia. In short, we need to train the diabetes team about the commonly attended religious festival in our locality, and patients should discuss with their doctor about the kind of dietary changes which happen during such festivals, and evaluate these patients completely, assess the risk factor, and accordingly we need to advise the diabetes management of these patients during these festival seasons. To summarize, festivals are the integral part of day-to-day activity, especially in Indian population. Both fasting and feasting can impact patients' long-term diabetes control as well as complications. There are definite guidelines for fasting, but there are no guidelines for feasting. But we need to control the postprandial hyperglycemia, especially by mostly lifestyle changes in these patients, so that their diabetes can be controlled very well. And we need to manage hyperglycemia during feasting with therapeutic lifestyle changes and along with that certain selected oral anti-diabetic agents to prevent the long-term complications. Thank you for your patient hearing, and my apologies for the some problems related to net which got disconnected for 2 or 3 occasions. My apologies for that. Thank you. If there are any questions, we are very happy to answer it.
Thank you, sir. Thank you very much. A very good talk on festival and diabetes. We all know India is a country with lot of festival, and we are a diverse religious structure. So there are festivals like which based on feasting as well as fasting. But all the festivals are actually of feasting only, and you have very well explain the things about the self medication as patient sugar goes haywire because of uncontrolled diet and lack of monitoring and complication arising out of it. And you have explained the management of this hyperglycemia during this festival season. On behalf of IMA, I actually, there is one query from Dr. Sanjay Devtare to Dr. Pramod Gandhi sir. Is there any Indian data on festival and diabetes mellitus? One question.
There are some papers, but mostly these are the review articles. There is no scientific study which is based on the festivals in India, but most of the review articles are, there are some review articles in certain journals on this during these festivals, because it is extremely difficult to publish paper, because there is no structured feasting or dietary pattern even in the community as well. So it's extremely difficult. But in day-to-day practice, we see that most of our patients during post Diwali or maybe post Holi, these patients are very poorly controlled, and they don't monitor as well their sugars. And if you monitor their HbA1c after 2 months or after a month or two, probably you see that their HbA1c is poorly controlled.
Thank you very much. As there is no question, one more question from my side to Ambulkar sir, as he has talked about the therapy, perioperative management of diabetes patient. We have seen, sir, in hospital setting, the lot of means all the physicians still they are using sliding scale, and you have already said that it's unphysiological, but what to do in some situation as the sugars we monitor and it goes up and down and mostly the hyperglycemia. So yes, of course, not sliding scale. Then how to manage it?
The most important therapy which I have told is multiple dose insulin therapy, where you use mix 50-50 in the morning, mix 50-50 in the evening, and regular insulin at breakfast, at lunch, and maybe at 4 p.m. This is comparable to that basal and bolus therapy. My experience with basal and bolus therapy is not very good. Whatever amount of long-acting analogs you give, the fasting blood sugar usually remains high. So in a stressful condition, when there is obesity, infection, and problems are there, then you must give mix 50-50 in the morning, mix 50-50 in the evening, regular acting at lunch, and some supplement of regular at 4 p.m. snack. If you give this and divide 50% in a 50-50 and rest in a regular, then probably the blood sugars will be high. Obese patient, infection patient, patient on steroids, their insulin requirement will practically treble during these episodes. Giving that sliding scale is not physiological, as I already explained. If the night time blood sugars are 280, and if you give 20 units and patient is not eating anymore, you will invariably land in hypoglycemia. The insulin therapy is given for the diet which he is taking and the time of blood sugar at the time of giving insulin, both the things, not only blood sugar at that given time, right? So that is the important thing to understand.
Thank you, sir. Yeah, means not means rush to control the sugar by giving just boluses. It should be
Yes.
gradual control.
Control
you.
over
Yeah.
less than 200 is acceptable value.
Yeah, sir, one more question, Gandhi sir, from our participant, Mr. Gautam, Dr. Gautam. I am on oral anti-diabetic and insulin both. My diet is controlled and usual, means regular, but my sugar fluctuate a lot due to stress. I want to eat chocolate after meals sometimes. I never used to do that. Do I need titration of doses? My HbA1c is 5.8 now. It was 7.1 before 3 months.
If he has already, if you have already achieved your target HbA1c, which is less than 6.5, currently your HbA1c is 5.8. I don't feel you need to uh, mm, up titrate the dose. But probably you need to find out whether you have multiple episodes of hypoglycemia, because at HbA1c of 5.8, we expect a lot of episodes of hypoglycemia if
Yes.
you are on any of these hypoglycemic agents, especially
Right,
sulfonylurea, insulin, maglitinides.
right,
If
right.
you are not
This,
on any of these agents, probably you can maintain, if you are on any of the anti-hyperglycemic agents like metformin, thiazolidine derivatives, DPP-4 inhibitors, SGLT2 inhibitors, alpha glucosidase inhibitors, then probably you can continue same dose. But if you are on any of the other agents like sulfonylurea, insulin, you need to reduce the dose, in fact, to avoid the hypoglycemia.
yes, yes. Actually, this question is from Dr. Sheetal. One more question. There is there? Uh,
Yeah, I can hear you.
no, no, Dr. Shailesh sir. Okay, Ambulkar sir, one more question from Dr. Sandeep Manvatkar. Can we use 50-50 insulin in pediatric population as we use usually 30/70?
That is the point, Sandeep. I'm telling you, one has to go for 50-50 rather than 30-20. Even if the child's diet is concerned, child diet is predominantly carbohydrate based diet. It is more than 60 to 65% calories are from carbohydrate. Even in those patients, the 50-50 in the morning and evening and regular at lunchtime is good enough. The prescribed therapy for IDDM is basal and bolus. You give basal, long-acting analogs at night, maybe in the morning, and give 3 boluses of short-acting with breakfast, lunch, and dinner. I would like to request you, you look after these children with their blood sugars and compare it with multiple dose insulin therapy with 50-50 in the morning and evening and regular at lunch. You will come to know the moment the child becomes 11, 12, 13 years old, his blood sugars are practically not controlled with basal and bolus analog therapy. But they are much better off from 12 to 15, 16 years with mixed insulin therapy, mixed given 50-50 given breakfast and dinner and actrapid given at lunch. This is because the counter-regulatory surge of hormone is so high during 12 to 15 years of age because pubertal spurt. And this so-called basal and bolus therapy is not providing good adequate results. I think my comments are open to discussion, but still you look at this point very carefully, and we need to collect data. Does really this is that much beneficial or not?
Uh, any addition, sir? Pramod sir?
Let promote talk. Yes.
This was about management of insulin in
Pediatric.
pediatric age.
Yes.
We are seeing a lot of type 1 diabetes patients, but somehow we are comfortable with using basal bolus insulin therapy in these patients, using Lantus along with glargine insulin along with the 3 doses of actrapid. Most of our patients are well controlled and we could achieve good glycemic control. Premixed insulins are good once you fix the dose, but probably in certain patients or those patients who are illiterate, probably where we use premixed insulins as well. Because patients who are illiterate, who are staying at peripheral villages, it's difficult to titrate and the doses. In such situations, we are using premixed insulins. Otherwise, we prefer basal bolus insulin in most of our patients.
Uh, one more question from Dr. Hital Amte, madam. Do you have any protocol? Do we have any protocol on diabetes management in leprosy affected people with diabetes? We can't differentiate the non-healing trophic ulcers many times whether they are due to old leprosy or because of uncontrolled diabetes mellitus. Pramod sir?
It is extremely difficult to differentiate between the trophic ulcers which develop due to leprosy and trophic ulcers which are seen in diabetes. But usually, the trophic ulcers which we see in diabetes are seen on the plantar aspect of the foot, whereas in leprosy there are due to neuropathy we also see the peripheral auto amputations of the various toes as well. If that is seen, probably we can see that these are the leprosy related ulcers, but otherwise management in both the conditions remains same. Offloading is the most important criteria, and if it is combined like diabetes with leprosy, it is combined, it is extremely difficult. We need to control diabetes, we need to do offloading, and we need to see that there is no evidence of any infection, or we need to control infection in such patients. That's the only way out for management in these patients.
Close this session. Thankful to all the speakers and Aditya. I thank you and good day to you all.
Thank